namanale manu yokye yen sai sami beshune sama kaldem je fama jogi wo yen sai sama kaldem ci nit ñu baax ñamu seqaloo ngir mënu fàtte ki la yaataloon ki la mayoo on nous jamais namanale manu yokye yen sai sami beshune sama kaldem je fama jogi wo yen sai sama kaldem ci nit ñu baax ñamu seqaloo ngir mënu fàtte ki la yaataloon ki la mayoo on nous jamais namanale 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 manu yokye yen sai sami beshune sama kaldem je fama jogi wo yen sai sama kaldem ci nit ñu baax ñamu seqaloo ngir mënu fàtte ki la yaataloon ki la mayoo on nous jamais namanale 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 manu yokye yen sai sami beshune sama kaldem je fama jogi wo yen sai sama kaldem ci nit ñu baax ñamu seqaloo ngir mënu fàtte ki la yaataloon ki la mayoo on nous jamais namanale 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 manu yokye yen sai sami beshune sama kaldem je fama jogi wo yen sai sama kaldem ci nit ñu baax ñamu seqaloo ngir mënu fàtte ki la yaataloon ki la mayoo on nous jamais
Hello everyone. A very warm welcome to all of you to today's webinar. My name is Irenaeus Dasobre, a member of the AFREhealth Health Economics Technical Working Group. We are very delighted to have all of you join us today for this maiden webinar of the Health Economics Technical Working Group. Of course, this is the first in the series that we are staging to roll out on the AFREhealth platform. So we have a very interesting lineup for today in terms of speaking, but just want to welcome everybody on behalf of the AFREhealth leadership, the Governing Council, Executive Committee, the Executive Director, Madam Georgina Yeboah. I'd like to acknowledge her presence here. And then also to entreat us that we are going to have a very lovely conversation webinar this afternoon. So we would entreat you to keep your microphones on mute. And then also during the talk, if you have any comments or questions, then feel free to put them in the chat. We are going to monitor that. And then after the two speakers have spoken, then we'll have some minutes for questions and then answers. So I will turn over to my colleague co-moderator to introduce himself and then also take it off from there. So Jesse, over to you.
Thanks, Irenaeus. Yeah, so Jesse Kikos is my name, and I'm a researcher, health economics researcher with the University of Birmingham, and also a deputy director of the teaching programs over there. So a very warm welcome to every one of us for this exciting first session that we're having today. So we have a team of two excellent and people with a lot of significant expertise in this area. So I'll quickly introduce them. So we're having, first we'll have Dr. Raymond Opong. He's a health economist and a researcher in the University of Birmingham. He's also an associate professor in health economics, and he is the director of all the teaching programs in the health economics unit within the University of Birmingham. So he'll be giving us a brief overview of health economics, particularly for those who might not be very familiar with health economics. Then we shall have Dr. James Asamani coming up next. He's a highly experienced health economics professional and health scientist who is based in the World Health Organization and is a technical advisor. So he will then give us a case study where we will take some aspects of health economics and provide a very timely and practical example of how health economics can contribute within the current environment. So, get yourselves ready. I know it's going to be a very exciting time as we listen to our two speakers. So without wasting much time, I will welcome Dr. Raymond Opong to take over. Dr. Raymond, you're welcome.
Thank you very much, Dr. Jesse. So let me just try and share my screen as usual and make sure everybody can see my screen. Okay, I assume everybody can see the screen. Okay, so yeah, thank you, Jesse. So this is, once again, welcome to everyone. This is the first in the series of webinars organized by the Health Economics Technical Working Group associated with AFREhealth. And one of the goals of this group is to build health economics capacity in Africa through the development of a webinar series. And so since this is the very first in the series of planned webinars, we assume that some of the participants may not be familiar with health economics. So what I'll be doing is I'll be presenting a very short summary on health economics. And we will not be going into too much detail, just a gentle introduction of what health economics is. So this is just a brief outline of the presentation today. So I'll explain the basic and fundamental concepts of health economics related to scarcity, choice, and opportunity costs. And then we will look at an overview or provide an overview of the main components and tools in health economics. So we'll be looking at things like cost effectiveness analysis, but to just be a brief overview. So we ask ourselves, what is health economics? And this is a very common and famous definition of health economics, which you'll find in almost every health economics textbooks. So health economics is simply defined as the discipline of economics which is applied to health. And so some of the key concepts which we look at, so the first one is the concept of scarcity. So we ask ourselves the basic economic question. So with the resources we have, the question is, what should we be producing with these resources? How should we be produce the resource? How should we produce what we want? And then for whom should we be producing the goods and services for? So in other words, we ask these questions because of the problem of scarcity. So for example, in an economy, we might want to decide whether to invest in the health sector or invest in the housing sector. And even if we decide to invest in the health sector, there's different aspects which we can choose to invest in. So we can ask ourselves, do we invest in curative services or do we invest in preventative services? So these questions all come about as a result of the fact that we have limited resources, and then we have unlimited wants. So, and then we have alternative uses of these resources. So a very basic economic problem of scarcity, which we try to solve. And I'll leave you with a quote here from a textbook. It says, no healthcare system anywhere in the world has achieved levels of spending sufficient to meet all the health care wants and needs. So this is just a basic problem of resource scarcity. And as a result of resource scarcity, which hinders us from meeting all our needs, we have to make choices concerning resource scarcity. And due to the nature and importance of healthcare, these choices are quite difficult and contentious. So for example, we might have choices between preventative services, curative services, or maybe end-of-life care. And then the question is, how do we choose between these options that we have? And once we've made our choice as a result of the choice which we make, if we choose maybe A or B, we have what is called opportunity cost. And opportunity cost is simply defined as the value of the consequences foregone by choosing to deploy resources in one way rather than in their best alternative. So in other words, it's the value of a foregone alternative. And it's very important concept because we are trying to value what was given up in order to meet our needs. And so I'll just give a simple example to help us understand the concept of opportunity cost. So if we have a choice, and the choice is how much of the healthcare budget should be devoted to every region in a particular country. And the decision which we take is to increase resources devoted to a particular region, maybe region A or region B. The opportunity cost will be the health foregone from the investment which we made in that region. So all the other regions would have to forego a certain level of health as a result of the choice which we made in investing in another region. So this, in a nutshell, is opportunity cost. So in terms of economic analysis, some of the key objective of health economic analysis is to promote the efficient use of the scarce resources which we have, and then ensure that the maximum benefit is derived from the resources available. So in the previous slide, we looked at the choices between A, B, and C. So economic analysis helps us to make these choices and make efficient choices. So just to summarize this, we have healthcare, we said we have scarcity, we have different options, and we need to make efficient choices, okay? And health economics could help us make these choices by comparing value. And when we compare value, what we're simply doing is we look at the cost of the interventions and then the effects of or benefits associated with the interventions. and then we define our health economics helps us to define the value for money associated with these interventions. So health economics primarily addresses the questions of resource scarcity from the perspective of efficiency. So sort of maximizing the benefits from the resources which are available to us. So we have different diverse set of tools which we use in health economics. So we will not go into too much detail in this particular session. Maybe in the subsequent webinars, we would explore them, but I'll just mention a few of them. So the first is the cost effectiveness analysis, where we're just looking at the value for money of different options in terms of interventions, programs, and so on. Another tool is what we call the budget impact analysis. So this is normally used in conjunction with cost effectiveness analysis. And the budget impact analysis is simply an assessment of the financial consequences of adopting a new intervention. So it sort of provides an understanding of the total budget required to fund an intervention. And then we also have fiscal analysis. So in the broadest sense, this just refers to efforts to create room within the budget for additional spending, while we are at the same time not jeopardizing the fiscal stability of the economy. And then we could also have efficiency analysis, which just looks at the relationship between inputs and outputs using tools such as the data envelopment analysis. So sort of maximizing health systems investments to generate the desired health outputs and outcomes. So these are some of the tools which we have in health economics. But I'll just focus on one of them, which is economic evaluation. And by definition, economic evaluation is simply the comparative analysis of alternatives in terms of both their costs and their consequences. This is the broadest definition of it. And from the definition, we can clearly see that it involves a comparison of two or more alternatives. We are examining them in terms of both their costs and consequences, and we normally take an incremental approach, which will become clearer in a few seconds. And so economic evaluation involves identifying, measuring, and valuing both costs and consequences of health interventions in order to provide the overall cost effectiveness of those interventions using an explicit criteria. And so there's different types of evaluation methods, but I'll just mention three of them, which are the most common, and they sort of differ in terms of how outcomes are measured. So the first is the cost effectiveness analysis, where costs are measured in monetary terms and outcomes in natural units, such as mortality. And then we have the cost utility analysis, where cost is also measured in monetary terms and outcomes in utilities, such as using tools such as the QALY and then the DALI. And then we have the cost benefit analysis, where both the cost and the outcomes are measured in monetary terms. So when we do a cost effectiveness analysis, we estimate what we call an incremental cost effectiveness ratio. And this is simply defined as the difference in costs divided by the difference in the benefits. So for example, if we have two options, option A and option B, say option A costs 12,000, the benefits is 1 unit or maybe 1 QALY. Option B costs £8,000, the benefit is 0.6 units or 0.6 QALYs. The incremental cost would be £4,000, which is simply the difference in cost. The incremental benefits will be 0.4 units or 0.4 QALYs. And then the ISA will be $10,000. And so if we look at just making the calculations a bit more explicit, so the difference in cost is simply the $12,000 minus the $8,000, and the difference in effect is the 1 unit of benefit or QALY minus the 0.6 units. And we simply get a $10,000 per extra unit of benefit. And so the incremental cost effectiveness ratio, it simply represents the cost per additional benefits. And we would normally compare the incremental cost effectiveness ratio to predefined threshold. But for this particular session, we will not really go into threshold. So the threshold determines whether the intervention is cost effective or not. So for example, the value of $10,000 which we obtained will be compared against the threshold to determine the cost effectiveness. But we'll not really go into that in this session. In subsequent sessions, we would explore cost effectiveness thresholds and decision rules. So just to summarize, so we've seen that health economics is the discipline of economics applied to the topic of health. So we are trying to fundamentally manage the problem associated with scarcity of resources in the healthcare sector. And then we've looked at some of the tools available, such as economic evaluation, which helps us to do this using explicit criteria. So thank you very much. And I'll hand over to James, who would present his.
Thank you very much, Professor Opong, for the brilliant recap of health economics and economic evaluation. It reminds me of my days in the University of Birmingham, and you guys were trying to put sense in the green heads. Thank you. So, colleagues, my presentation would look at an application of economic principles in health workforce. And this application, I normally say that I try to bring health economics as much as is possible to the health science people, while at the same time, I bring a little bit of the health science to the health economics people. So more or less, I'm trying to be a betweener between health science colleagues and health economics colleagues. So what you would see would be a blend of both health science and health economics. I will try to be as brief and practical as possible. So my presentation will look at forecasting health workforce needs, supply, and cost implications for achieving universal health coverage. And I will draw largely from one of our recent works that is a tool for doing this type of modeling. We've done a couple of works, starting from my days of training in the University of Birmingham. Professor Ray Opong was one of my supervisors. I was actually the lead supervisor. We developed a model as well, and we will have another opportunity to present that one. So there are different approaches to it, and this is just one of the approaches. So I will be providing the conceptual framework, and for the interest of those who may want to explore it later, a bit of how the numbers are calculated, and I will provide an applied example in Ghana, where I will look at the supply side of the model, the need, the gaps, and look at economic feasibility analysis, which is the budget, the fiscal analysis that Professor Opong mentioned a short while ago. So to put this work in context, globally, the ministers of health met in 2016 at the World Health Assembly and adopted what is called the Global Strategy on Human Resources for Health, which has 4 objectives. The second objective is better fitting for what we're trying to do. That objective says that countries need to anticipate and align their investment in workforce to meet the future needs of the population. And so in the Africa region, what has happened is that the Africa region, the ministers of health in Africa also met in 2017, adopted a regional approach to implementing this strategy. One of it is that by 2022, which is this year, at least half of the countries should have done an investment plan for health workforce. So this involves significant amount of economic analysis. And that by 2030, all countries should have done the same. So this involves not only just doing economic analysis, but looking at also the fiscal impact analysis as well. So from this, the same strategy now gives us a direction as how we should move on as a global society in terms of planning for health workers. It says that countries should build capacity to plan, and their capacity should look at being able to quantify what are the needs, what are the demands, and what is the supply. So once you go into the realm of what is demand and what is supply, then definitely you can't run away from applying economic principle. Now, it also defines need, say that we should look at need purely from the population perspective, the disease burden of the population. So this is where really looking at health science or public health intersecting with economics comes in. So WHO has developed some tools, and one of it is a tool to do this type of analysis we call the health labor market analysis. And so the picture to your left is a guidebook for that, and the link to it is there for those who may want to read it further. So this guide actually shows how countries can analyze the supply of health workers, the demand for health workers, and the need for health workers, and look at the feasibility and impact of different policy options. So the last point here basically is about economic analysis. So what I would like to do today is to explain when we say the need, the demand, and the supply of health workers, what exactly do we mean? And how do we analyze that in practice? And so the rest of my presentation will focus on that. When we talk of the need for health workers, the need usually is about answering the question, how many health workers of what caliber is required to be able to make a population become healthy or remain healthy? It has nothing to do with how much can you pay. It's about, from a pure professional point of view, how many are required to make sure the population remain healthy or they become healthy. Then we look at demand. Demand is given how much we have, whether as a government, as a private sector, donors included, how much can we afford and we are willing to spend to employ health workers to be in the health facilities and the health system to provide service. That is called demand. So you can see need is completely different from demand. In many instances, the need could be so big, but the demand here is restricted by how much we can afford. So demand is sometimes lower than that of need. But it takes a bit of some macroeconomic elements and prioritization and political action to translate what is needed to become the demand. Then you can look at the issue of supply. It's supply for health workers is how many health workers are available and willing to find jobs to do at the current level of wages or income. That is what usually supply is. So it's not about how many workers are in the country, how many are willing to find jobs. They are either they are employed already or they are unemployed and looking for jobs. Now, if you compare need and demand, you'll find a certain gap. And that gap is something that we usually will call it the need to demand gap. If you compare demand and supply, you find a gap, assuming that the demand, that's ability to pay for positions that will employ health workers is 100. And the number of health workers available to looking for jobs are 80. You have a gap of 20. That gap, the demand is more than the supply. We call that one a demand-based surplus, shortage of workers. There's shortage of workers because the demand is higher. If it was the flip side, where you have the ability and willingness to pay for positions to employ workers is 80, but those available to look for jobs is 100, that difference of 20 becomes what we call the demand-based surplus of workers. It doesn't matter if the need, you've calculated the need is 2,000. What matters is what the budget is able to pay for now. So these are the three main concepts that we're going to look at going forward. So first, let's tackle the issue of need. So if we look at, we say need, theoretically, the need for health workers is derived from the need for health services, which the economists here will tell you is also derived from the need to what? To remain healthy. So it's a derived from the need for health services, which is service also derived from the need to be healthy. So it's derived from derived. So it's a secondary derived need. So how do we capture this? There are four main elements that we usually use to capture what really need is for health workers. The first one is who is in need of health service, the population. So we look at the population in terms of the size of the population the gender distribution, the age cohort, and the geographical distribution of the population. Then we are also interested further in looking at what is the disease burden, what actually confronts this population in terms of what kills them, what makes them fall ill. And so we usually focus on the prevalence and the incidence of diseases and their risk factors and injuries. That covers the majority of the population. Then the next one is, what service has been planned already or is otherwise appropriate to ensure that the people are free from these diseases and risk factors? So those services are those that we call the essential service package. Then the next one is where the health professionals comes in. If one of the services is to provide an OPD consultation, how much time will it take the one appropriately trained to deliver one OPD consultation? And we call that one the professional standard for service delivery. And this is usually an interdisciplinary process that is used to do it. So we have developed a model for doing all of this complex analysis from the need, from the supply, and integrating together and looking at the economic implications. I will pick this in 3 different aspects. The green part, which is the need, the one on the bottom, which is the supply, and then those in the middle, which is the economic component. So if you look at the need part, how we derive need is that we look at the population, how many people are there. You can look at it by region, by district, by community, or just one as a country. Then what is the gender of this population? What's the gender composition? What is the age cohorts? Pregnant women, under 5, young children, adolescents, young adults, among anyhow that the population can be segmented, because different age cohort would have different needs or be suffering from different kinds of diseases, and therefore different interventions are required. Then we look at the location. Are they in rural areas, in urban areas, and that. Then we move to the health need, that is the disease burden. What are the risk factors? What is the prevalence rates of the different diseases and risk factors? What public health interventions are appropriate to address these ones, and what are the coverage levels? Then we come to the other one, which is the service package. What interventions are appropriate to address all these diseases? How much time will they require a health professional to do that? And how often should this service be rendered to the people in need? If you put all of that together, we come up with what we call the need for health services. So we estimate the overall need for health services. Once we estimate the overall need for health services, we can now ask the health professionals, how much time do you spend on this? Then we can, if the overall need for, let's say, outpatient service in one community is 100, and one health worker spends 10 minutes to do one outpatient service. So if we take 100 divided by 10, you will get 10. The 10, we call it the standard workload. Those who are familiar with WISN would appreciate this term. That is the workload that beyond which you can't do much. Anything else you do would be substandard, to below what is professionally accepted by your own standards. So we put them together and we come up with the numbers required to address the different diseases and risk factors in the country or in the locality, and we aggregate together to get the overall need for health workers. All of that I've described, the formulas to calculate it is here. I will not be going through that. It's for the interest of those who would like to read it. Then when we come to the supply side, we actually try to track right from school enrollments, and the tracking looks at how many people are enrolling in the different schools for a different program, say for medicine, for dentistry, for pharmacy, for nursing, for midwifery, among others. Then we get that quantity, we look at how many are dropping out and how many are eventually graduating. And those who graduate, then we also look at, are there people who migrate from other countries to come and join? If they all join and they have to write the license exams, how many will pass? So we do all of those adjustments and we come up with the total number that will come out to join those already existing. Then don't forget, those existing, some are likely to die, some will retire, some will migrate abroad. All of that we call the attrition. We need to also adjust for it. And those who are even left, not everybody wants to practice their profession. We know health professionals who are now business tycoons who are no longer holding anything, doing anything that would serve a patient directly. So we also adjust for what we call the labor participation rate. And we come up with what is the effective supply, how many workers are really there and being made available or ready to be made available to serve the population. So that's how we calculate that. And so also the formulas to calculate that is also provided for the interest of those who want to read it further. Now, if we compare now the two, so we've looked at calculating need and calculating supply. If you compare the two, we can now come up with, we can now make a sense of something. So we can compare the two in absolute terms. So I need 10 doctors, I have 5, so I have a difference of 5, which is a shortage. Or on the other side, I need 10 doctors, I have 15, so I have a surplus of 5. So that we call that one the absolute comparison. That absolute comparison is important. If you get that absolute number, that is what we use to now engage training institutions to adjust their admissions and adjust their admission policies to ensure that we can have a good balance between what is needed and what is being supplied. Then we can also do the comparison in relative terms. So if I need 10 doctors and I have 5, so what I have, which is my supply, I'll divide by the 10 and I'll get some 50%. What in relative terms, I can say I have 50% of the doctors I need at this point in time. Now, that type of comparison is important for you to compare between different categories of workers to be able to prioritize which one to focus first. And I'll give you a typical example in the case of Ghana in the analysis we've done. With this, we can look at the cost of everything, the cost of the employment, cost of training, and we can compare all of that to the budget that we have available. And we can use that to also advocate for improvement in allocation in the health sector, and in particular for the health workforce. So basically, this is the empirical, the conceptual and empirical model that we're using. And we have put this in published papers, and for the benefit of those who want to read, the first paper you see, which I've put a picture with the red top, is a summary of all the evidence of how this has been done over centuries. So, and the next one is putting that in mathematical form and also attaching an Excel spreadsheet that people can, who are not mathematicians, who don't want to do a lot of calculations, can just put in numbers and they get the result. And the last one to your right is an application that has been published from Ghana. It's been applied in so many countries, but the others are still to be published in scientific journals. So for those who want to download this tool that I've described, the conceptual model, you download and just put in figures and get an output. We have a tool designed in Microsoft Excel, which is to your left, the picture of that, and the link to download it is what is provided to the right. So if you click on that link, it downloads a tool for you. It has already data that has been published publicly from Ghana. So it shows you where to delete the Ghana data and put your context-specific data. So permit me now to showcase a few things from the Ghana analysis. So from the supply side, if you look at this graph tells you the number of people enrolling in different programs in Ghana for more than 10 years, between 2003 and 2016. You can see that there are jumps at certain points in time. For example, you would see that in 2009, there was a big jump in admission for nearly every program. And before then was 2005, where there was some jumps. If you take in particular, let's say physicians, you will see the numbers from 2003 was a steady thing, 200 plus, 200 plus, 200 plus, then it doubles around 2006 and remain around 400 plus and doubles around 2003. So what it means is that there is some bit of knee-jerk, maybe time point adjustments that tend to be massive expansions. We later will see the impact of these expansions on, for example, wages, for example, budget. And now if you look at this particular one, it gives you another thing, which potentially is a bit troubling, is the blue line you see there shows how many enrolled nurses Ghana plan to produce each year, how many they are planned to admit. And then the slightly red line tells you for those same years, how many were eventually admitted. You can see a big dichotomy. Apart from 2006, that was the beginning of the process where they admitted what they planned to do. For all the other years, even the second year, they had gone more than double. And by the time they are in the last year of the plan, they had already done more than 3 times. So this tells you that there was an incentive. What was possibly the incentive in not following this plan? The incentive was simple. Of course, principals were also very worried about making more money to run their schools, among others. And of course, politicians were also interested in having a nursing school in their constituencies. Now, the impact of that is this. Look at the age distribution of workers in Ghana in 2008 versus 2018. If you look at 2008, which is the slightly bluish line, and the 2018, which is darker, you can see that the workforce generally has suddenly become very young people. 66% of them are now between 25 to 35. And previously, 25% were 46 to 55 years, which you can argue were people who would have been considered mentors or were now into training and teaching, mentoring and leading. And that appeared to have been wiped out. There's now only 8%. Now, if you look at that of medical officers, there's no big difference between the overall picture and the picture of medical officers. And you can still see that it followed the same pattern in between 2008 and 2018. But if you look at that of professional nurses, you can see that there's already been a divergence. In 2018, for professional nurses, we had just 4% of them being 46 to 55 years. Meanwhile, 10 years back, they were about 26%. So you can see the divergence. Now, what is even more shocking is that of midwives, where there's been a complete demographic shift. For them, you will see that in 2008, majority were 59%, 46 to 55 years. In 2018, more than 70% were 25 to 35 years. So you can see the big demographic shift here. The implications of that for service delivery, for quality, among others, is something that we do not know. But one thing that is sure is that this group, at the same time, would also want career advancement and progress, and therefore it will be surprising if many of them are asking their employers to go to school further, and that will have implications on budget. One thing also that we are taking into account in the model is attrition, and you can see that attrition rate for some categories of workers in Ghana is slightly above that of the global average. And the Ghana average attrition is about 3.6%. Some workers are higher. I'm sorry to indicate that this data may already be outdated, because with COVID, we are aware that many health workers, especially nurses, are now living almost in buses to other countries like the UK and the US and other places. Now, with this model, we've put all this data of intake, attrition, and all of that in, and this is what it tells us what will likely happen if the trend remains the same over the next 10 years. There would be roughly 78% increase in the number of general practitioners in the country, from 6,000 to 11,000. And you see that nutritionists will increase by more than 1,000%, nutrition and dietitian put together, from under 350 to more than almost 4,000. And you see pharmacists will increase by 247%, from about 1,000 something to 3,600 plus. And so if you look at it, the rate of increase, the lowest rate of increase would be what? General practitioners, and followed by pharmacy technicians. Now, if you were to look at the nursing cadres, you see that midwives will increase by 156% in 10 years. General nurses would increase, but not too dramatic, about 50% increase in 10 years. And the reason why that is the case is some of them are moving into specialty areas. And then also enrolled nurses will increase by 109%, from 37,000 to more than 77,000. And community health nurses could increase by 90%. One of the things about community health nurses is that a lot of them are moving out of that bracket, and enrolled nurses too, to become general nurses and to become midwives. They are now virtually, the means to do that is now pretty open, different dimensions, other weekends, sandwich, and almost every university has that type of course crash courses for them. Now, if we were to compare this kind of supply, this is how many would likely be in the system, to what would likely be the need, let's see how it will look like. So in the need, remember I said the need for health workers is derived from the need for health services. So we first must be able to estimate what is the need for health services before we can estimate what is the need for health workers. So the need for health services, using all the parameters I spoke about, the 4 parameters, population size and demography, disease burden, package for interventions to address the disease burden, and then professional standards. And thanks to colleagues here, particularly Mrs. Georgina Yabua who did a brilliant work around staffing norms, which part of the data entered here. So you can see for different types of diseases and risk factors, this is just a selected few to fit the slide. We've estimated what would be the number of services required in terms of visits. You can see malaria still leads the pack, around 11 million visits, and there's complications around stillbirth is the lowest, around 11,600. Now we can compare this and take, let's say, for example, OPD visits by region to compare with what is actually seen to see what are the gaps. So you can see each region, and based on this analysis, what would be the expected OPD consultation should everybody have access to universal health coverage and use the services that they require. But if you compare that to what was actually seen in about 2020, you can see that there is a big difference between what is the need in the population versus what was seen in facilities. And you look at it in proportional terms, the country was doing only 36% of the need for consultations. So that tells you whatever the gap is, you can argue it's not a workforce problem alone. It's about medicine, it's about infrastructure, it's about logistics to move around. But workforce is really a big part of that. Then if you look at it from admissions perspective, you can see the highest admissions were expected in the Ashanti region, of no doubt because they also have the largest population. But if you compare that to what was really happening and look at it in proportional terms, Ashanti region, apart from Northern region that did just 9% of the expected admissions, Ashanti region and Greater Accra seem to be the lowest, in terms of proportion of the expected admissions, nationally around 37%. Now, if we translate that into how many workers are required, we find that for doctors, for general practitioners, we require a minimum of 14,000 doctors, and that could rise to 26,000 or 89% increase within the next 10 years. I'm just going to choose and pick, and you pick that of the nutritionist and the dietitian. We needed about 5,000. Remember, the current numbers are less than 350, but the rate of increase is slow. If we hit the baseline need, the rate of increase is slow, just 9% in 10 years. And if you look at that of pharmacists, 110% increase in the requirements from 3,900 and something to 8,000. If you look at that of the nursing cadres, you would find that of midwives, 14,000 is required. And remember, we already have 14,000 from the previous slides, and this could increase to about 22,000. It's about 60% increase in 10 years. That of general nurses, about 87% increase in 10 years, from almost 67,000 to 125,000. If you were to look at it from this perspective, the rate of increase in that of midwives, and you compare that to the rate of increase in the supply compared to the need, you will see that the rate of increase in supply is outweighing that of the need. And so let's make a sense of it. Let's compare now the two and see how it looks like. To put 11 categories of workers that I've demonstrated here together, Ghana would have needed in 2020 about 201,000 health workers, and this was increasing between 3.3% to 11%. And the stock or the number that were available was 148,390, was increasing on an average of 5.6%. We can say that Ghana potentially met 67% of the need if you look at the aggregates, but if you go into the nuances, 5 out of these 11 cadres, we didn't even have 50% of the need. And if we were to look at that one, you can see that of general practitioners, the need is in green line, and then the supply is in blue line. You can see that there's a gap at the beginning between them, but what is worrying is that that gap is widening over time. And as the years go by, the gap widens if nothing is done to bridge this gap through different mechanisms like reducing the disease burden, increasing more training, and retaining them, among others. And you look at pharmacists, a similar pattern, although the widening of the gap with the pharmacists appeared to be less dramatic as compared to that of the general practitioners. And look at that of laboratory scientists, and the widening in that gap is dramatic. And you look at that of lab technicians, and the gap there is even wider than the scientists. And you look at that of enrolled nurses, and the gap is little. And with time, the supply would definitely outweigh that of the need, even though majority of them are now moving away to become general nurses and midwives. Then you look at community health nurses, and the need is higher than the supply, and the gap appeared to widen a little bit over time. And this is a bit of worry because the CHIPS concept in Ghana, for example, relies heavily on community health nurses. Then you look at that of midwives, which is interesting. And even already in 2020, the supply was already at almost the same level as that of the need. And as the time goes by, although the need is increasing, the supply is increasing at a faster rate. And I told you this is because we have multiple streams to become a midwife. There's direct, there's moving from community, moving from enrolled nurses, and they can move at different levels. They can go to the midwifery school and do 2 years. They can do a weekend or sandwich with the universities, and it's at both degree and diploma level. So there are multiple streams, and that is why the growth in the supply there is quite fast. And we expect that there will be a need-based surplus. That of nurses, you can see that until recently, when there's a surge in out-migration, there was almost an equilibrium between what is needed and what is being supplied. But this equilibrium is now being opened up, and then there's a gap that is beginning to widen. That is more driven by recent outsurge in out-migration. What is the implication of all of this for those who are into health professions education? The implications are that for some cadres, we need to increase the intake, for others, we need to decrease. In particular, we could decrease that of enrolled nurses by 2%, and that of midwife by 21%, and we could increase the others. You can see the levels of increase that this should be the optimized level of admissions that have the greatest shortage in 2020. It was not a doctor, it was not a midwife, it was not a nurse, it was a nutrition dietitian, followed by a lab technician, followed by a pharmacy technician, followed by pharmacists, followed by laboratory scientists. How much will it cost to train them to fill all these gaps? This is how much it costs us in US dollars. How much will it cost to employ them when they finish school and to join the cost of those already being employed? This is how much it costs. But money matters. If we know how much it's going to cost us, now how much money would likely be available would be an interesting question as well. And this brings us to what Ray spoke about in terms of fiscal analysis. So in analyzing this is the approach, and thanks very much, Dr. Jesse Kigozi, who is the architect of designing this model, this aspect of the model. The size of the economy, and we look at, if you look at the size of the economy, that is how much is the country worth in terms of all its output, how much money is there, and how much growth is taking place. Now, if that one, how much government can get, we usually think depends on how much taxes they're able to collect, how much grants they get from donors, and how much they can borrow. Now, if we put all of that together, there are some expenditure government will do which they have no discretion. For example, they must pay interest payments for loans they borrowed in the past. They must do statutory payments. They can't just run away from that. It is after doing all of that, whatever money is left goes into a general government expenditure where government will now decide where to spend that money, whether on roads, on social services, among others. Now, when they do decide that, whatever comes to social services is in that basket that we can get some money for health sector, what we call the general government expenditure on health. And so it's usually a certain percentage of how much government is spending on broadly its programs. In Ghana, at the moment, at the time of analysis, every expenditure government makes was coming to the health sector. And it is out of this that the health sector will now decide how much to spend on wages and salaries, which becomes the funding for employment of health workers. So we can break this down and see how much it is. To simplify this and not to be talk too much economics, we've decided to put this in lines that will make it very easy. Now, if you look at over time, between 2000 and 2009, this is how much government has been putting priority in the health sector. So every amount of money government spent, this is the percent that was given to the health sector. You can see that it's very clear, irrespective of what is on paper, the health sector across governments is no longer, I say across government because this is not just within one particular regime, it's no longer seen as a top priority for government spending. It's a top priority for government action, but not spending. You can see the line is dropping. Now, if you look at the health sector budget, how the total budget of the health sector in US dollars is the blue lines. The red lines are how much money is spent on the health workers, and the line at the top shows what is the percent that is spent on health workers. You can see there are ups and downs depending on the context in the country at the time, but we're dealing with the most recent figure is around 63% in 2020. And this data is from the Ministry of Finance in Ghana itself. And if you take the average of the last 5 years, you roughly find around 58% of the health sector budget is being spent on health workers. Now, what is critical to note here is when workers are employed in the public sector, it's hard to sack them. So anytime the priority shift, what they do is they stop new recruitment because they can't sack those already there. So anytime you see that the workforce budget is going down, that means recruitment is restricted. So you can see for all the years that you see that the red bars are lower, that means recruitments were restricted. Now, if you compare Ghana, is Ghana doing too much? If you compare Ghana to the rest of the world, averagely, the world countries are doing an average of 57% of their health budget on health workers. That is what is being spent on health workers averagely in the globally. But if we were to look at Ghana, Ghana is around 58%. The average between 2010 and 2022 is 58%. So you can say maybe Ghana is 1 percentage point above the average level globally, and but not definitely over the rooftop. What then it tells you is that if Ghana is looking at its peers, it will be hard to say that increase the proportion of money spent in the health sector for workforce. You can only argue that they need more money in the health sector, which may trickle down to health workers, but it's hard to argue to increase the proportion for health workforce further. Now, if that is the case, now let's look at this graph. I will take 2 minutes here because this graph is important to summarize everything we've talked about. The blue line you see down there, which is written private sector contribution, tell us how much the private sector is willing to pay for health workers to be employed full-time in the private facilities. It's only 20%. The private sector is contributing to only 20% of the health workforce employment opportunities in Ghana. It's not that they are not booming. The private sector is very booming in the country. The reason why this is the case is that they rely a lot on what they call locums or dual practice, where health workers sometimes allegedly work during the day in the private institution and sleep at the government facilities in the night in the name of doing night duty. So that is how much money the private sector is contributing. That line, which is written budget space for public sector, I hope that is purple. That purple line demonstrates how much, looking at the analysis we've seen in the past 2 slides, how much money would be available from the public sector to employ health workers. If you put the 2 lines together, it gives you that red broken line, which is how much money would be available in the country, put public and private together, that would be there to employ health workers. Now, anything that goes more than this would be difficult to afford, given the level of prioritization that the health workforce is within the health budget, and the level of prioritization in the health sector is within government overall expenditure. Now, the black line you see is the cost of employing the health workers who were currently in the country in 2020 and who are likely to complete school and join the workforce going forward. You can see that that black line, in 2020, it was slightly below the red broken line. That means that in 2020, the health sector so much, they have more money to employ nearly every worker that was available to be employed. But as the time goes, and from 21 already, it's higher that of the red broken line, employ them is now being more than addition in the budget. The difference between them will represent unemployment. So we are already expecting from this unemployment of health workers in the country. And this expectation of unemployment of health workers does not mean that the country has more than what it needs. This is just because of what they are able and willing to spend on. That is the demand. So the demand is getting lower than that of the supply. But if you look at what is needed, which is the green line, you can see that even up to this point, the need is higher than even the cost of employing those who come out of school, which is represented in the black line. But we do expect that around 2025, if nothing is done to streamline the admissions into training institutions in line with the need, we are likely now going to be having, if we employ everybody, we will now becoming a lot more inefficient, because we would likely now have people who are employed who the system, based on the disease burden, may no longer be needed, but there will be some areas that are needed that they will not be employed. So that is where the inefficiency will come in, and Ray's point about efficiency analysis will become very important at that point. So as a way to conclude, this type of analysis has not been limited to Ghana. We've done it in other countries. You can see the Ghana one to the left, you can see that of Kenya to the right, and the situation is not too different from Kenya, except that the magnitude of the lines are different. So more unemployment are expected in Kenya than we see in Ghana. You can see that of Lesotho, and you can see that for specialists only in Zimbabwe. And you can see one key thing here is that in Zimbabwe, for specialists, they have more money than those who have been trained to employ. Maybe you can argue that levels of remuneration is low. So a number of countries have used this type of analysis to inform policy and strategy, from Namibia, Rwanda, Sierra Leone, Ethiopia. Ethiopia is still ongoing, by the way, and also the Southern African Development Community, which is made up of 16 countries, they've adopted this for a regional strategy. So by way to conclude, let me demonstrate to you that economic analysis do have impact on policy when it is well presented. If you, those who are in Ghana will remember around 2016, this famous thing, a hungry nurse can kill. These were unemployed nurses demonstrating for jobs almost every now and then. This was April 2019. This issue was there because of budget constraints. It never stopped. By 2018 February, it was still a similar problem. And unemployed nurses were giving government ultimatums for employment. This was February 2018. Deliberately, I've put them together to demonstrate that this cut across different governments. Now, from analysis, using this type of economic analysis, we generated evidence to show that really, indeed, there was shortage of health workers in the country. It was not the case that we had more workers than we needed, that people were unemployed. And that even the Ghana Health Service alone required almost 44,000 health workers. But we also demonstrated that more than 12,000 health workers were distributed to places that were inequitable. And that led to 28% of the wage bill being, you can call it, lost to maldistribution or inequitable distribution. This type of evidence was presented to the Ministry of Finance during the budget hearing processes. And fortunately, they sided with the analysis of the Ghana Health Service and the Ministry of Health and increased the budget. In fact, the original budget ceiling was increased, and that allowed for employment of over 54,000 health workers. By 2019 April, more than 30,000 of these had already been employed. And you can see that the news started changing from hungry nurse can kill, giving ultimatums, and now government recruits about 54,000 jobless nurses. So this is to demonstrate that doing the analysis is not for its own sake, it's not an end in itself, but using it for advocacy can lead to some policy action. So to conclude, I would say that taking a labor market perspective, using an economic angle to analyze health workforce issues is extremely important, and it has potential for impact. How this is done, there's no one-size-fits-all analysis. Every context is different and every cadre is different. The analysis needs to be tailored to the context. We have provided tools that are useful for this, and I hope that you will find them good when you do want to use them. These are the references to the papers and data that I referred to. Thank you very much for the opportunity to share with you.
Right. Thank you very much, Dr. Asamani, and then Dr. Raymond, for the very great presentations that you have given us this afternoon. Rather, unfortunately, we would not be able to have time for Q&A, but we've taken note of the questions that people have posted in the chat box, and then we'll try to respond to those questions and then circulate them to the group via email. We'll just want to, we are mindful and then being sensitive of people's time, and then the fact that there is another webinar lined up later in the day. So we just want to thank everybody for taking the time to participate in this maiden webinar, and to encourage you, if you're interested in joining this technical working group, and then if already you are not a member of AFREhealth, you sign up and then choose to be a member of this technical working group. You can send an email to info@afrehealth.org for any further inquiries that you may have. So just to say a very big thank you to the leadership of AFREhealth, and a thank you to the Secretariat for assisting to put this together, and then my colleague, co-moderator, and then the speakers. Thank you, and then we wish to see you in future webinars. Have a lovely day.